context. So first of all, I'm Laurie Crawford, and I'm with the Virginia Department of Social Services. And up until March 1st, I was the project manager for Virginia Heals. Now we have, y'all get this hot off the press. We haven't even gone to press with it yet, but DSS is standing up an Office of Trauma and Resilience Policy. And I am heading that office. So we literally will make the announcement next week. So all of this work will continue. It will just fall under this office. So just FYI on that. So, but to give you a little context, so Virginia Heals, Virginia was one of like 4 states in the country that was funded by Department of Justice for about 6.5 years to better link systems of care for children and youth. So the idea that all these different systems, whether it be behavioral health or juvenile justice or education, kind of all have their systems of care, but they don't necessarily talk to each other. They don't necessarily engage youth and families in the process. And what we want to do is kind of prevent that system involvement, and then to really make youth and family centered referrals and identify them early. So that's kind of a very big rundown. We did a lot of stuff over the course of the 6.5 years, but one of them was we developed, the main thing was we developed a trauma-informed model of service delivery and a supporting toolkit. And so this screening tool is part of that toolkit that met one of the 3 primary objectives of the grant, which was to identify children and youth who have experienced trauma as early as possible. But just to kind of give you an overview quickly, so this is like the graphic of the trauma-informed model of service delivery. And you'll see that on the left side of it is really the things that are applicable to agencies and organizations. So looking at policy review, family engagement, and training staff. And then the frontline worker piece of it is the identifying the services, so screening for trauma and making referrals. So those kind of frontline workers that are working with children, youth, and families. We have, I'll share my website with you. If you go in, there's a resource, there's a toolkit item for each of these sections on the trauma-informed model of service delivery. So there's e-learning and toolkit resources that are PDFs, and so on and so forth, that are all on virginiaheals.com website. And that's just Virginia spelled out, heals.com. So just to kind of give you a bigger context, because this was a lot of work, and the screening tool was a very heavy lift because it involved evaluation of piloting. And we felt like for a long time we were a screening tool project, but we did do a lot of other things too. So we didn't just want to be, we identified them, but then what to do next. So, as part of this toolkit, we have a trauma-informed agency self-assessment, which is really an opportunity for organizations to figure out where they fall on the trauma-informed care and resilience-focused continuum. And there are 10 different domains in that. We do have an online version that if folks want to use it for their agency, we can create a link, and then we can, do your report for you. I was very impressed that someone in Southwest Virginia yesterday, they implemented their agency, and over 300 staff completed the assessment. So it's really good for like planning making your strategic and action planning for making your agency more trauma informed. Then we have the family engagement guide, which is really just a starting point. We have an e-learning course that's probably more comprehensive on family engagement. And then we have a community resource mapping facilitation guide, which is like a playbook that you can, gather 25 to 30 people in community representing all the different systems and identify your resources, really with a focus on identifying community-based resources that we may not even think of as services, quote unquote, but really looking to try and build on those existing supports without getting them system involved. And then the screening tool, and then a referral and response protocol. So all of these things are on the website, and I'm happy to share in the future if any of you want to hear more about any of the other items. Okay, so our screening for experiences and strengths, or C's, is a brief screening tool. Brief meaning it takes in the almost 4 years that we piloted it, it takes about 15 to 30 minutes to do it, depending on how they answer. And there's 3 age versions. So there's a 0 to 6-year-old version that is administered to the parent or caregiver, and then a 7 to 12-year-old version, and then a 13 to 21-year-old version. And they are all look at the exact same items. They just use different language. So obviously 0 to 6 is third person, because you're asking the parent or caregiver. 7 to 12, you're using language like private parts instead of, so it's just language changes to be more age and developmentally appropriate. We do have it now in English and Spanish online, and we had it in Spanish on paper too, but now we've got it online in Spanish. I'm actually been waiting for one little fix to be made, but I'm going to be probably announcing that next week, because that was quite a journey. If any of you know, trying to get something we finally were able to find someone who speaks Spanish and is an expert in trauma-informed care to do that for us the third go round. So it actually, we feel confident with it right now. And then the idea is that it does not to make a diagnosis, it's to support referrals and the need for additional support and or services. So it is a brief screening tool, not an assessment, and it was designed to be used whether, again, like everything else in our toolkit, whether you're in behavioral health or education or child welfare, that anyone who's received the training on it, we do have an e-learning module online. Anybody who's received the training can do it, because it's not a clinical assessment of any sort, but just really a starting point. Right now, I know ACE was mentioned in June, so just in 2 months, the Department of Juvenile Justice will be implementing this screening tool statewide as a part of every social history that's conducted on a child or youth. And it will be a part of it. So it's not the social history, but they were using the ACE as a screening tool, which I'm sure you all know is not designed to be used with kids. And it's a great instrument, but it's not to screen kids with. So they are going to be replacing the ACE with the screening tool. And right now I'm in the midst of training all like 650 probation officers in the state in 25 4.5-hour sessions with DJJ. So that's happening now. We're actually going to be presenting at the judicial conference for J&DR judges next month in Charlottesville, because we want them to know what's coming so they'll know if they see it. So just to kind of go through the main parts of the tool here, essentially, after getting some demographic information, we do not have any PII on our screening tool. If folks want to use it in their own system, they can, but because we have an online version that you can save, print a PDF, we don't want to warehouse that information at DSS. We don't want it, but folks can do whatever their normal filing system is. So it's some brief demographic information, and then go to the section on identifying victimization. And as you'll see, it's pretty much, it certainly doesn't cover all of trauma. It focuses on, it was a Department of Justice Office for Victims of Crime training, and it's a brief screening tool. So you're not going to cover everything that's out there, but essentially it starts anywhere from, like, have you ever been a place where you saw or heard physical fighting between neighbors or people at school, to when you get down to the questions at the bottom about, has anyone ever taken pictures of you naked, touched your private parts with any parts of their body, so going into potential sexual abuse, pornography, possibly sex trafficking. Again, you'd need further assessment if they say yes. So for any yes answer in this section, you ask whether it's happened in the last 30 days, and then whether it was a parent or caregiver, obviously to assess immediacy of need and risk to the best that we can. The beauty of the online version is that it makes sure that you do this, because it won't let you go further if you don't answer all the questions. So if they say yes to anything in this section, it goes to the reaction section, which I feel is probably the more important. The more important piece, because, I'm preaching to the choir here, but, two kids can have the same exact thing happen to them, and their reactions can be completely different depending on, the level of support, they have in their lives, and whether they've gotten help before and that kind of thing. And so this question is where you find out if they have any symptoms from it. So based on what you just told me, have you had trouble sleeping? Have you not wanted to eat, or wanted to eat more than usual? Found yourself wanting to be left alone? And those are Likert scale questions. And I should mention that on these, so this is not a point-based, like if you get 4, then you do this. This is really totality of the information that you have in front of you, because again, each kid is going to be different. It's going to be based on how they answer this section. But we kind of say, if they say often or always, then that's where, you might want to have, if it's something that's often or always bothering them, then that might be, an elevated level of risk. On the have you ever, the threat of harm to self questions, the last 3, those are obviously just yes or no. And so, for example, in the protocol that we developed, the procedure with DJJ, if they say yes to this, then they have to inquire about how recently, how they're feeling now, that sort of thing, based on the answers to that. And then my favorite part of the screening tool, which we were told when we went around and got input on what we should include, everybody said, we really want you to include something on protective factors or resilience, and we want to use a strengths-based approach. So even if they say no to everything in that first section and you skip over the reaction section, you still go to this section. So that way you still ask them these really, tough questions. And then you're going to talk to them about where they find support, whether it's from their, their parents or caregivers, or whether it's from extended family or mentors or their friends or their friends' parents, because that's what we found a lot by talking to kids, that maybe they found that their friends' parents were a big source of support for them. And that way, what we want to do is really just, again, use that strengths-based approach, and also use this information to guide those conversations about next steps and who's a trusted adult that you can talk to that can help you follow up on any referrals and that sort of thing. And so that is the rundown of the screening tool. There's the online module is at the end of it. You get like the access to the tool, and it's literally like 35 or 40 minutes the course is. But we have 2 courses. One is on trauma-informed screening, just in general, whether you use this tool or not. And then another is on this particular screening tool. So we recommend they're both taken, but we recognize that this tool was never meant to be mandatory for anyone. I mean, DJJ is making it, as part of their social history, but essentially it's a resource that if folks are clinicians and they're doing another more detailed assessment that covers this stuff, then they don't want to go back and do a brief screening tool as well. But if they're not doing anything, then this might be a good way to direct services and referrals and just find out more. Because what we found was that we looked all over when we originally got this funding to see if there was a screening tool that was truly brief and not an assessment, and that covered an array of different sources of trauma. And we found that there wasn't anything out there that there were like tools for like dating violence and tools for sexual abuse and tools, but there wasn't anything that really looked at a wider array. So that we weren't trying to reinvent the wheel, but we just wanted, that was a deliverable of the grant, and it was piloted in pretty much every setting except for schools. And that is because of the consent issue with consent to participate in research. It just made it extremely difficult because those conversations are not something that should be like an you have to opt out of. So we didn't feel that, and they just didn't have enough, to go through this consent to participate in research three-page form. Even there is no grade level for that form. It's not, it doesn't, it's very, very difficult. So now that we're not in research anymore, it's a lot easier. Do you all have questions for me?
Laurie, so other than Department of Juvenile Justice, who else is, either has used this in the pilot or is thinking about using it?
Well, it's hard for me to measure how many, I know the different agencies that are signed up to use the system and stuff. And so we've got like some domestic violence programs. We don't have like another system. So we've got some domestic violence programs. We've got like St. Joseph's Villa in Richmond. What is there's a foster care, and I'm just blanking on it now because it's UMFS, United Methodist Family Services. They are doing it. So we've got like some big groups like that, and then agencies here or there, but we don't have the system wide is only DJJ. We have gotten, we've always, this project as a whole had to have partners from all the different systems. And we've had, particularly with education, I've had a lot of support, but everybody, it's kind of like with DJJ, everybody in education wants like a couple of school systems to do it first and then show, so they will have a model for how it's done. That's, and in DJJ, we did pilot in DJJ. But it was a great process that we went through developing this procedure. I learned a lot from it because we really looked at, okay, this is made for use in any system, but how do we make it work in this particular system? And we really want to be aware of things like implicit bias, and to make sure that doesn't mean that it has to be like universal screening, that every single kid you see is screened, but it could be every single kid who comes in with X, Y, and Z, and not just that they look like they're at risk, if that makes sense. So say there's truancy problems or, whatever. So there's a certain, that every single kid in a particular group is going to be screened. And so in DJJ, they're doing it initially for every kid who gets a social history, either predisposition or post-disposition. But we hope after another year or two, we can find opportunities to do it earlier in the process, like before they get to the point of having a probation officer. That's kind of the goal is really, but right now it was just easiest to take it exactly where they were doing the ACE, see what we get, and then look for opportunities to maybe do it at intake. And then, so when we piloted it in Richmond City, they screened every kid who came in on an assault charge. That was how they piloted it. But with the online version, we can run reports by locality or by agency if folks, want their numbers, and then and the report goes into kind of, because when you get to the end, I didn't show you a screenshot, but when you get to the last piece, that's when you fill out, you say, did you refer them internally, externally, where you referred them? And so, some of that information is captured on the report as well. And then it summarizes whether it was a family member, how many had a family member or caregiver involved, and all of that. And there is also on our websites, if you're interested in looking more. So, I'll just give you an example. When we piloted it in a couple of social services agencies, domestic violence program, in juvenile justice, as I mentioned, in like Ready Kids, which is an organization that serves kids who've experienced trauma, but also a child advocacy center. So it was like a variety of different settings, and a home visiting program, which was very interesting because Healthy Families in Hampton piloted it. And then they found that a lot of the moms were saying, I could say yes to these questions. And it is applicable for up to 21. So, it's just kind of we developed it to be used kind of across all settings. And there is flexibility, and we always train. So if there's an issue, so say you've got an 8-year-old or a 9-year-old, and developmentally you think that they, should be the younger age tool, or, whatever, that's fine. There's just a comment section at the end that we recommend that people note it there, because, just give them more information. So it's not like, but once you go into the online version, if you put in an age, it's going to take you to that specific tool. So.
And then Laurie, is there a charge for this, or how do you, no charge? So
No charge.
That's
I'm
nice.
I'm just budgeting my maintenance for the online system right now. I'm recruiting 2 policy specialists for this new office, and I can't wait to have help, because whenever something with the system, we have to have testing, this Friday night at 7:30, I get to do testing. And I can't wait to not be the only one on there, because so when this grant project ended in March of 2021, so just last March, and the year before that, we were put in the governor's budget to continue funding. And then when COVID hit, we were taken out of the budget, and then we were put back in. So it was a very interesting time period of not knowing if I was going to have a job in a month. And so now that project is over, so 25% of each of the the policy specialists that are going to be coming on board is going to be to continue to support all of this Virginia Heals Toolkit implementation and work. And then we're just going to be really expanding. We're doing a lot of, work around what does a trauma-informed agency look like, and how do we support our workforces and that sort of thing, which I'm super excited about, because I think, if nothing else, COVID made that all the more apparent. And really looking at secondary trauma, and then trying to take all of the trainings and guidance documents and everything that's done in DSS and look at it through a trauma-informed lens. And there's no way we can go back and do all of it, but as things are being revised and updated and developed, there'll be we'll be supporting all the other work that's going on. So it's pretty cool.
And Tanya, you took that training, right, through juvenile justice?
Yes, I was in the first training. So I've been trained for, I don't remember when it was, but I've been trained for a while, and I've actually administered the Cs already. So it's pretty easy to use. And
how was it, working with one of your clients going through it?
It's a client that I had for a while, so it's someone that was already pretty familiar with his background. They'd come back to me on probation again. So I'd done ACEs with them previously, and since we're still technically using ACEs until our new fiscal year starts, it was kind of let's practice and get in the habit of using it. So I did the ACEs and the Cs, and they line up pretty well. And this kid's technically an adult, so I was using the
13 to 21-year-old.
Yes, thank you. Sorry, my medication causes some brain fogs here and there. The 13 to 21-year-old. So, but his level of processing is actually more along a 10-year-old. So the wording is actually really good, because he was still able to follow along really well. So it works really well with these kids. Because they're definitely, a lot of the kids we get, unfortunately, are not, I don't want to say they're not bright, because they are, but their education levels are not where they should be.
Mm-hmm.
So, but it was easy to follow along with. He unfortunately just did not go with any of the recommendations that would have helped him out, and he's no longer with me. He's now with adults.
That's too bad. Yeah, it's juvenile justice was actually, I felt like that they were really got a comfort level pretty quickly. That's the thing, is a lot of times it's you get nervous before you get familiar with the language of asking the questions, but after you do it a few times, and I know just with me, as long as I've been working on this, it was still until I started doing these DJJ trainings, and that we have as part of that training, there's a vignette, there's a video of a simulated screening, and then we stop it, at certain points and go back and review. Did everybody get the same? Did they score it the same? Did they hear the same thing? Were there any questions? Some kind of pro tips that, if you've done it long enough. And now it's like, I feel like just having done those trainings that I've done a bunch of screens because I'm going through and asking each of the questions, but they will, I do have that video too. And I know they're recording. So DJJ, we're doing live like this trainings for all of their folks in these 25 sessions, but then they're going to have it available via a webinar for new staff or for partners that aren't required to take the training, but who it would be good for them to see it.
Yeah, and the hardest part I had with the kid that I used it with was he wouldn't answer the question of where the trauma came from. He refused to answer any of those questions, which told me that it was all familial, which I was familiar with his background anyway, so I knew it was all familial and I knew where the trauma came, having worked with him for so long. But that's going to be our hardest part, is getting the kids to answer of, okay, where did this trauma come from? Who perpetrated it against you? And that's always the hardest part with getting these kids to answer us anyways.
Yeah, because you can't, and I should have mentioned, you probably saw in there, they can skip. So when you go through the introductory script with them, you let them know, of course, they can stop the screen at any time, or they can skip any questions that they want. That we really, make that clear that's, so even if they're DJJ, they can still skip it if they want to skip a question. But I always train and say, sometimes you learn more from what they don't say than what they do, and for instance, if they get to, and this happened in piloting with DJJ, if they get to those last 4 questions that are about sexual abuse, sexual assault, they've answered all the other ones, and then they get to those and they're suddenly like, skip, don't want to talk about it. That's probably letting you know that something, has happened in those categories. They're just not at a point where they are ready to share it yet, but it still gives good information for you. I mean, even just what they skip on. So, but if any of you, I'm not going to hold up your meeting any longer, but if any of you want more information or want to talk through any of this anymore, like specific to where you are, that sort of thing, then just, should I send this presentation out or send, I mean, the website has all my information on it too, but you tell me what you prefer.
If you could send us the slides, that would be great.
Okay. Yeah. I will get those sent over to you and then y'all can share them out, but do feel free to contact me anytime.
Okay.
All right.
Thanks, y'all.
Thank
I
you.
appreciate it. Thanks for the opportunity.